Hi, everybody. Welcome back to my live webinar series. And today we have Dr. Rebecca Lewis joining us from the UK. Hi, Rebecca. Thank you for being here.
Hi, thank you for inviting me. It's lovely being here. Thank you.
So I'm going to let everybody know a little bit about Dr. Rebecca, and then we're going to get straight into the Q&A. So you've had a pretty interesting life, I have to say, Rebecca. I love reading your bio. So Rebecca's medical career started in anesthetics, and then she changed specialties and became a GP in 2000. She continues to practice as a GP, which is over here, I think, called primary care provider, PCP, but the generalized doctor, yeah, and has developed an interest in menopause, yay for us. And she gives lectures and she writes articles on the subject. She is determined to improve the understanding of menopause in current and future generations through education and access to accurate, evidence-based medical information. She is passionate about making menopause, or you call it in the UK, the menopause, and I really don't know why that is. We have menopause here and the menopause over there. Maybe someone with a grammatical lent can help me with that one. Anyway, she's passionate about making menopause a much more positive experience and enabling women to get back to feeling themselves again. Rebecca has two young children, and you're a fitness freak as well, which I love.
Exactly, yeah, that's good.
And so did I cover everything there?
I think you've covered everything, actually, yes. I think that bio was written a few years ago because my young children are grumpy teenagers now.
So you don't have two young children. Yeah, it's like my personal training one. It says I've been in the industry for 2 decades, and I'm like, it's 30 years now. I'm older than I think.
Yeah.
So Rebecca, you are a GP and menopause specialist at Dr. Louise Newson's clinic, Newson Health. And I would just love you to just please tell everyone who's listening today, like a general overview of what that looks like in your everyday life and what your goals are within the practice.
So you may have heard of Dr. Louise Newson, who's actually a really leading figure in the menopause in the UK. She's really done wonders for empowering women and giving knowledge to women so that they can get the right treatment for them. She's really changed. We need to rebrand the menopause, and that's what our campaign is really about, changing people's views about it, because there's so many entrenched wrong myths, really. But anyway, I am a director at Newson Health with Dr. Louise Newson, and we set up this clinic. Well, Louise set it up, and I joined her 2.5 years ago, and it's grown enormously because women aren't getting the right treatment, really, and find it difficult to get the right treatment. So we have this clinic in lovely Stratford-upon-Avon, and as well as seeing patients, a lot of our time is spent educating GPs, healthcare professionals, women themselves, going around doing talks, writing. Louise does a lot of media work as well, which helps because the media is so powerful and as a result of the media has caused a lot of myths as well. But actually getting the information out there that's right and accurate, because it's so confusing as a woman trying to navigate your way through menopause at the moment. And hopefully that's making a change. So yeah, we now have 35, nearly coming to 40 doctors working at Newson Health. And you know, it's become, we've also Louise has founded a charity for the menopause, and I'm a medical advisor there, and a director of Balance app, again founded by Dr. Newson, which is a free app which helps women, we perhaps talk about that later, understand their symptoms and have you. And also a director of Newson Health Research and Education, which is a not-for-profit company set up by Newson Health to research more into the menopause, which is desperately needed. Yeah, so that's me, really. I don't do any general practice now because, of course, you can imagine my life is so busy with the menopause, and it's my absolute passion. I absolutely love talking about it. I love helping women. It's one of the most rewarding things, and you've heard I've had a varied career. One of the most rewarding things I've ever done in medicine.
Oh, that's really great to hear, and I see it getting the media coverage as you said, in the UK. I don't see it getting the media coverage of it here in the UK, and yet there's some amazing advocates for women's menstrual health and menopause health over here. Dr. Jen Gunter is one, and Dr. Heather Hirsch is another. Yeah. I really would like to get more traction, but I think we're all connected. It's really nice to see that, you know, we've all got this end goal. So I have a lot of questions. I'm going to go through all of the questions now, and I'm hoping that we can, I'm just going to mute. Please keep your phones muted, please, ladies, because it really does help us. There we go. I think I might have muted yours, Rebecca, which I didn't mean to do. You did. Oh, God. Hold on a minute. I'm so sorry about this, ladies. I can't even find Rebecca. If you don't. Okay, yeah. Please keep your phones muted. It's just very helpful. Okay, let's get straight into the questions. A lot of the questions were very personal and specific, but what I found is that they're very common questions, and so I'm going to give you like an overview of them, and hopefully you'll find this helpful, ladies. So, question number 1. So I'm keen to find out at what stage I should be seeing a menopause specialist. And this is a story I hear and a question I hear all the time, because maybe menopause symptoms aren't that challenging for them. There are some impactful changes, but they're able to sort of cope with them. And they're doing lifestyle things like exercise and nutrition to stay on top of things, but preventative measures and where HRT for those who aren't sure, and I'm pretty sure most of you are, is hormone replacement therapy, where that fits into the picture. And is it even necessary? Does everyone have to take it?
So it's a good question, because actually, number one, identifying that you are in perimenopause, the time before the menopause, when the hormones are fluctuating and we're getting symptoms of that the ovary is beginning to fail, is actually very difficult. And even I find it difficult to know when I was perimenopausal, and didn't realize for some time. So it's really, number one, understanding when it's happening, which can take some time because it's insidious in onset, really. The symptoms are multiple, and they come and they go, especially in the early stages, as the ovarian function is normal, then it's not, it goes down, up, down. So what we tend to do as women, and it's quite understandable, is we say, well, of course I'm not sleeping and I'm anxious. It's because this is going on in life. You know, we have busy lives in the typical age group. We have often young children, elderly relatives. We might be working really hard in our careers at this time. You know, there are lots of reasons. So we normalize a lot, or we're getting stiff and achy because we're getting older. You know, that's what we think.
I love that. We do normalize. Yeah, we do.
Don't we? And I spend my time saying to women, this is not normal. It is normal, but it's not, it shouldn't happen, if you see what I mean. Women do get stiff and achy because they're losing their hormones. So identifying that, number one, is really important. And then I would say, when you are realizing you are perimenopause, go get help, go and ask, at least get good evidence-based information about what's it about. Make sure you understand what's happening with the hormones, and they are failing. And the most important one is estrogen. Estrogen is dipping and dropping.
And that's how they got involved in the system.
Rebecca, I've thingied you again. I've muted you again. This is why I shouldn't be allowed to do.
I'm unmuted now.
I literally shouldn't be allowed to press buttons.
Don't worry at all. So it's the beginning of the estrogen levels dropping. And so not only does it give rise to symptoms, from which are many and varied, but it has health risks. Living without estrogen long term can cause a lot of problems. For example, we are 5 times as likely to have a heart attack when we lose estrogen after the menopause. We have an increased risk of osteoporosis. We have an increased risk of dementia, of type 2 diabetes, of obesity, a lot of diseases which are going to affect our physical health later on. So we know that treatment with HRT is very, very safe for the vast majority of women, and should be thought about at least and discussed, because if you manage to get treatment earlier the better. There's this period called the window of opportunity. Okay, it is 10 years within your last period, but the earlier you get it, then before the body can have a chance to remodel without estrogen, the estrogen is replaced, and the damage is damage limitation of potentially what could happen with living without estrogen. So it protects the vessels in the arteries, helps stop build-up of atherosclerosis, the fatty deposits in the arteries. It helps the bone density maintain itself and keep strong. Helps the muscles keep strong and stop something called sarcopenia, which is a weakening and wasting of muscles that can happen. So I think really the earlier the better when you're experiencing symptoms, and if you can identify that makes the conversation so much easier, especially in the UK in our primary care. Is if a woman goes in who's informed, say, listen, I know I'm perimenopausal, I'm still having my periods, but I've got these symptoms which may or may not have hot flushes or sweats. Everyone thinks it's about hot flushes and sweats, but it's so much more than that. And I'd like to talk about my treatment options, because I know that potentially there's health risks for me. I'm actually really sick of not sleeping, and my mood has dropped, and I'm more anxious, and I would like that to go. And I'd also like to protect my health. And so then the conversation will ensue, should do, about HRT, which is the sort of first line treatment for women with symptoms in order to protect their health and improve their symptoms.
See how many notes I wrote then? I mean, I've heard this over and over again, Rebecca, but it's just so important to reinforce the message all the time. And I saw all of the questions coming into the chat, and I want to sort of like just build on what you've said. So can you talk a little bit about when you said this window of opportunity? Because Colleen said, you know, she's 57. Is it too late to start? And I want you to talk about because I know people have this in their 70s and 80s, but why? How is it different? What are the things that doctors need to be looking at when someone has sort of maybe missed that window of opportunity or is getting towards the end of it? And when is it like? When is it too late? I think I said
it's never too late. It's never too late. So we have people in the 80s and 90s on HRT, and the time length for taking HRT, there is no time limit. So that's an important thing to get over. But let's get back to the 57-year-old lady. The average age of menopause in the UK and probably the US is about 51, which means the date of your last period. So she's within that window of opportunity, because she's within 10 years of her last period. And that's really the basis of what the studies have been done on. The women within 10 years of their last periods to have shown these wonderful gains from hormone replacement, halve their risk of heart disease, reduce their risk of osteoporosis, bearing in mind 1 in 2 women over the age of 50 will develop osteoporosis before they die. So it's a huge thing for us women. And decreased risk of dementia, type 2 diabetes. So she's certainly within the window of opportunity, and you know, could safely start HRT. If someone has been 15 years without hormones, so she may be 65, HRT can still be started, but it needs more of a discussion and an individualized basis. Depends what type of HRT, we'd be selective as what type of HRT we used, and start perhaps at a lower dose. There's less studies there really to show how much benefit it is on all the other, on the health of the cardiovascular risks. And some older studies have shown with oral estrogen that there was perhaps a little bit of an increased risk of cardiovascular disease in the first year of taking HRT in older women. And other studies have shown the opposite. So there's a little bit of we don't quite know and if it does cause increased risk or not. But with the transdermal estrogen, that means estrogen through the skin, there's no increased risk of blood clot. And one would assume that should have less risk starting in mid-60s. But the studies haven't been done in this particular age group. But using logic, it should be safe to start, and we often do.
Right, good. That's great to confirm that. And then what about those women that maybe well, I've got 2 questions I'm going to ask you in one go. One, if somebody has started HRT, stopped it, probably whether by choice or often their doctors will still use that logic. One, can they restart? And then the second part of the question, which somebody asked, is if HRT is not an option, if it doesn't work for them, or they choose not to, what are other options outside of lifestyle stuff I'm on about, like from your like medical perspective, can be done? So can you restart? What are the treatment options?
Yeah, you can restart. You could restart. Okay. Of course you can. I mean, I can't think of any reason. If you're, say you stop it at 50, say your last period was 51 and you stopped it at 53, you thought, actually, I feel rubbish. I want to have another try, perhaps a different type of HRT. Perhaps I wasn't what we call optimized, which is your estrogen levels weren't high enough in your bloodstream to relieve your symptoms. So a lot of women stop HRT because they just didn't really feel better on it. And that might be a number of reasons. The estrogen wasn't high enough. And they needed to go up on the dose, but they didn't have a specialist that could guide them on that. They may have had problems with progesterone. Some people are great with progesterone, others don't.
That's one of my questions. So we'll dig deep into that one. Okay,
we'll come on to that later, shall we then?
Yeah.
So there are reasons and there are ways around it, and there are workarounds often. So quite understandably, that's why people get stopped, or they stop themselves. But if they in 2 years think, yeah, I'd like to start again, yeah, that's fine. That's fine. So yes, you can stop it and then you can restart it. You know, I have started HRT in an 80-year-old very gently and slowly. Because her symptoms, that's the other question. Sorry, I'm leading into another question for myself. Should I do that?
Yeah, do it, yeah.
People think, oh, well, what I've got to do is get through it and my symptoms will disappear, you know, in 5 years and I'll be fine. Now, that is not right. And that's an important message to get across, because we don't really know how long the average set of symptoms last. Now, there are studies that have said, oh, well, it's 7 years or it's 8 years. But yes, some symptoms abate. So if someone has had terrible flushes and sweats, they often do settle after about 5-6 years. However, other people, number one, they don't settle. And I do have 90-year-olds who are still having flushes and sweats, would you believe? So some poor ladies do carry on. And also a lot of symptoms such as the low mood, the increased anxiety, what happens is people compensate for that after years of feeling so dreadful with their anxiety. So what happens? They give up their job. They stop driving. They never fly. And gradually their world becomes smaller and smaller. So if I was to ask a lady who's perhaps 70 and she'd had terrible time through her menopause, she said, you know, I'm fine now. And that is because she doesn't do anything. She has a very limited life, perhaps sits at home. She can't go driving. She can't remain independent. So I would argue probably the anxiety is still there, but she's managed to contain that anxiety by decreasing the external stressors. So basically to share with you that it's a very difficult thing to say how long do they last.
Exactly, yeah.
But one thing, that's symptoms. The other thing is, whenever you have HRT, it will always, even if you start at 80, it will always build bone density. That is one thing that is proven. And when you stop HRT, your bone density will decrease again.
Exactly. So, and then the flips, that's a great answer. And then the flip side of that is, what if HRT isn't working for them? And I do actually want to touch on that, because I know I've had to play around because I'm super sensitive. You wouldn't think it about me, but I'm a very sensitive girl. But we'll talk about that later. But if HRT is not an option for whatever reason, what other things can you talk to your patients about?
That's important. So number one, there are other medications you could take. So SSRIs, which are antidepressants, can be used for hot flushes and sweats, actually. They're not as effective as HRT, but they can settle those down for some women. So some women would choose to do that, and that can help that. Unfortunately, it doesn't really do anything for your muscle pains or your insomnia necessarily, or in fact, although it's an antidepressant, it doesn't always treat the low mood, usually of menopause, very well. And of course, it doesn't do anything for your long-term health risks in terms of replacing the absent estrogen. But there's those things. And gabapentin is another medication that could be used for hot flushes, and various other medications for flushes and sweats. CBT has been proven to help anxiety in the menopause, and has been proven to help and diminish the frequency of flushes and sweats for many women. So that can be very helpful. And it can also help insomnia. So I think the same as anyone else, if they have terrible insomnia, it's looking into that. It's looking into mindfulness, relaxation techniques, getting out of analyzing the patterns of thinking, really, that being aware that perhaps one's catastrophizing, overthinking, and doing something about shaping the way they're thinking, and challenging the anxious thoughts, and challenging the way their pattern of thinking, so to encourage a more neutral way of looking at situations, or a more positive way. But that takes quite a lot of work.
Yes,
and
that's work.
One-to-one CBT, but that can be very helpful for people. Lifestyle, really important. Well, Amanda, I can't say much in front of you because you're the expert, but of course it is the regular exercise for men and women, for our thinking about our increased risk of cardiovascular disease and obesity. Regular exercise and weight-bearing exercise. It is doing the weights. Yeah, it's doing the weights for the muscle, which we lose muscle mass, called sarcopenia, muscle mass and muscle strength. And many fitness people will know that. They don't need me to tell them that, because they suddenly go, I'm working out and what's happening? My biceps are not, I just feel a bit more flabby and it's ridiculous. Or I'm a great runner and I'm really putting my effort in and my times aren't going down, so it helps, it's really important to look after our muscles. Weight-bearing exercise, take vitamin D. Everyone over the age of 1 should be on vitamin D. Well, certainly in the UK, because we're a very cloudy country and we don't get enough sunshine. And of course, vitamin D is essential to absorb calcium in our diet for our bone health. So vitamin D, low dose, is a guideline in the UK. And having a diet that's healthy, which means vegetables and fruit, and less processed food, and rich in calcium. There's a good calcium calculator I could mention, which is the University of Edinburgh calcium calculator. If you put that in, that's a really nice, easy peasy, put in what you're eating and you can say if you've got enough calcium in your day, because it's better to get calcium from your diet rather than supplements.
Yeah, that's all great. So that's really great. So there's options out there for sure. And I know I don't want to take up too much of my story, but just to sort of reinforce what you said, when I first found out I was in perimenopause, I was scared about HRT. It was 8 years ago and I wasn't educated, and I chose to go on an antidepressant, venlafaxine, which did help with my depression at the time. And I know the off-label benefits of the vasomotor symptoms, but then when I started having the GSM symptoms of vaginal atrophy, it obviously couldn't help with those. It couldn't help with a whole multitude of symptoms. So it's a team effort often, and especially I think women that can't or choose not to go on hormone therapy, it requires a little bit of everything. That's what I am seeing.
It does, Amanda. It's a little bit of everything, knowing which areas of your body are affected and doing something for that, which can be done. And even if you're on HRT, you still should be doing it. You can't have HRT and sit down and think, right, lovely, have chips all day or whatever. And you still have to work at muscle building and weight strength bearing, vitamin D, etc. So that's
great. It is, but I think that a lot of us are all adding to that conversation, this holistic approach to, our health. And essentially what we're doing is looking after our health, right? Okay, so I'm going to move on. Now, this is a very specific question, but it may be interesting for everybody to hear. And somebody contacted me who has an underlying chronic health condition. It's actually something to do with her kidneys. She has a nephropathy.
Nephropathy, yeah.
Neuropathy, yeah. But so people who have got underlying conditions, what's the consensus about taking hormone replacement therapy for those? No contraindications.
So underlying health conditions, I mean, I'm taking out of this question people who've had hormone sensitive breast cancer, estrogen receptor positive breast cancer, but people who've had migraines, who've got kidney disease, liver disease, high blood pressure, high cholesterol, gallstones, people who are overweight, because that is obesity is really like a disease, can still have HRT. But what I would say for all health conditions, it should be estrogen taken through the skin. What we call regulated body identical HRT, because this is the safest and the best type of HRT. And this involves estrogen as a gel or a patch. And the reason for this is if you have estrogen through the skin, it goes, you rub it onto the skin, or you have a patch that delivers it, goes straight into the bloodstream and goes all around our body, and it bypasses the liver, unlike an oral estrogen, which goes through the tummy into the liver and it's metabolized. If it's through the skin, you have no increased risk of blood clot and no liver damage at all. If you have it through the as a tablet, it is metabolized by the liver, and it increases our clotting factors a little bit, and can interact with that more with things, and that increases our risk of blood clot a small amount. It's not a huge amount at all, but if you have any of those conditions, you may increase your risk of blood clot or have problems with the liver, with the gallstones or the cholesterol. So it's best just to keep away from the liver and have it through the skin. And really, I don't know of any medications if estrogen is through the skin that would be a problem with that, or any other conditions aside from estrogen receptor positive breast cancer.
I understand that the risk goes up to from 1 in 1,000 to 1 in 2 to 2 in 1,000 with
something. I think it's one. Yeah, 1 to 3, isn't it?
It's so statistically, it's statistically insignificant. I understand, but still, there's no need to put yourself at that risk if DVT or blood clots are in the family,
in your background anyway, and also because it's purer. It's not metabolized to different estrogens. So in the liver, you have the estradiol. It could be identical to our estrogen that we produce, 17-beta estradiol from the ovary, but it will be metabolized in the liver to different types of estrogens, which aren't as effective. It's not as physiological, because what happens, the ovary fails, we fail to produce 17-beta estradiol, because there's several types of estrogens.
Yeah.
And the 17-beta estradiol is the most important, it's the most effective, and it's what our body is missing. And by using the gels or the patches through the skin, that replaces like with like. So for me as a doctor and a physiologist, if you like, it is perfect. That's all HRT is replacing. It's not high dose like the pill, and it's just topping up what the ovary is failing to do, and replacing it at a normal female level. So it's very natural, and it's very safe, and they're derived from the yam root vegetable, which I like it. It's a nice derivation source, and it's more effective because it goes to the receptor, it fits on the receptor most perfectly, and it induces all the changes we want it to induce in the cell.
That's awesome. And I just want to clarify for the US people listening that a body identical in the UK essentially means regulated. That doesn't exist in the US, that terminology. I think you actually, I think Louise created it, that's why. And in the US, the US, we simply have regulated and unregulated. And essentially when it's unregulated, your insurance won't cover you. And when it's regulated, you can get it on prescription from your doctor, and it's usually covered by insurance. And it's gone through the FDA approval for efficacy, safety, and all those protocols. Okay, so moving on, and this is that was a nice segue into the next question. I've had a lot of questions saying, but what is the perfect dose, or what is the most specific prescription that the doctors should prescribe for us, knowing that in the US there are no nice prescribing guidelines like they exist in the UK, that you're at the whim of your doctor. The North American Menopause Society have guidelines which their practitioners are supposed to follow, but as well as knowing what the right dose is and what the right prescription is, somebody also said to me, are we looking for perfection, or are we looking just to feel a bit better? Like, because some people go on and it never feels quite right, does it? So it's all about like how the dosage happens. And I wonder if you can...
That's right. It's about the dosage and the type of HRT. And so I would always say that what we call regulated body identical HRT, because that's the most natural and as the most effective and the safest. These are derived estrogen and progesterone from the yam root vegetable. The estrogen is always given through the skin. And in our clinic, we give it as a patch or as a gel, and you can taper the dose. You can increase the dose according to the response. And our responses are all going to be very different, because our dose is as unique as we are, and our menopausal symptoms are as unique as we are. For some reason, I find it fascinating. Some women are drenched with night sweats. They have to get up and change their sheets every night because they are that, and other women never have a sweat. So that's how varied it is on that one symptom. And there are a multitude of symptoms, about 34 or more, 45 symptoms of the menopause. So it's very varied, as is our dose, and there are reasons for that. So you cannot compare with your girlfriends. You cannot compare what dose they're on and see. It is about tailoring the dose, and that's what we do. It's a very individualized approach. So we like to, and it's symptom led. We do like to drive it so that the woman symptoms are gone. What's the point of being on HRT unless it really helps, or you really try to make it help? And so a lot of people think it doesn't work for them, which there are sadly some people that it's not so good, and that's fair enough, and they've tried. But a lot of people think it doesn't work for them because they haven't had that expertise in really getting the right dose for them, or changing or doing workarounds if they have a problem with progesterone or a problem with the estrogen.
How often, while you're on that, Ben, sorry to interrupt, but how often should that type of thing be reviewed with your specialist?
So I start someone and I always review them in 3 months. You need that time to see the effect of the dose, because it takes time to work. And then we add the dose, increase the dose if we need to, according to symptoms. We do measure blood tests once someone has been on it sometimes to make sure, but in the perimenopause, they fluctuate so much, they're not that useful. But they can be more useful when you're established on HRT to make sure you're absorbing it. We have a tenfold, I was talking to a lady today in the clinic and telling her there's a tenfold variation in absorption through the skin. So some people are going to use much more, but have the same level as some person who's using a tenth of the dose. So some people might need 2 or 3 patches, whereas the other one might just need 1 patch. And that depends on your skin. There's nothing you can see. It's just how it is, and the number of vessels we have on the surface, and how much what you're drinking and what you're eating and how much exercise you're doing. All these things affect our metabolism.
And your genes as well, I suppose, and genetics. Yeah.
Genetics, absolutely. Yeah. So there's not a right dose, but there's a right type, in my opinion, and that's the regulated body identical HRT. And it's using estrogen, and we have to use progesterone. The reason we use progesterone is because if you have a womb, estrogen's brilliant. We love it. It improves our growth. It grows the skin, it grows the hair, nails, muscles, helps the brain, but it will also thicken the lining of the womb. And so to prevent that, you need a progesterone to keep that thin, because thickened lining could go on to something more problematic if it's left. So progesterone keeps that thin. So you need estrogen and progesterone, and we also use testosterone, which may be news to some people, but testosterone is a really important female hormone. The ovary produces 3 times the amount of testosterone to estrogen. Now the ovary is now failing, which is what happens obviously in the perimenopause and menopause, and that's normal and natural, but our testosterone levels would drop. And testosterone is incredibly helpful for not only libido, but concentration, memory, fatigue, mood, and sleep as well. We're finding that that really can help that. So we often add in testosterone. So what this is, all this process is called optimizing the HRT for the individual that you're treating. And you should have regular consultations to make sure that you're getting better, and you have no side effects, and you're tolerating it. And if you're not tolerating it, we're onto it, we can change it and do something about it. So that's kind of my approach, and I think is a good approach. Once you stabilize, you just need to be seen. In the UK, we must see you at least once a year.
So so essentially, if HRT, you feel like it's working but not quite enough, go back and get a review, because it may not be the correct dosage for you. And then also know that as you go through perimenopause to menopause, the dosage might need to change anyway.
Yeah, that's a really good point, really excellent point. Yeah, because I say to my ladies, actually, we're chasing a moving target.
Yeah.
Because your ovary is producing, say we should be up here for estrogen, and it's dipped, it's gone down to there in the perimenopause, and you're getting symptoms because you're a bit too low. I'm afraid with time that ovarian function's only you're not on ground zero yet. It hasn't gone right down to zero. So you might be fine on a quite smallish dose to start with. 6 months later, you're falling off a cliff. You say, oh my goodness, what's happening? The flushes are coming back. I'm not sleeping, my anxiety, it's not working, on stop HRT. No, it's because you need a higher dose to bridge the gap. So it's chasing a moving target in the perimenopause. Yeah.
Excellent. Okay, so I have 2 more questions. I'm going to start with progesterone intolerance, because that follows on quite nicely from what you've just spoken about. It's something I've struggled with. Yes. I know Nick Panner from the International Menopause Society has written a report on it. Louise has been very vocal about it. Not every woman does well on the micronized progesterone. And I wondered if you could talk a little bit about like what progesterone intolerance is and what steps a woman can take who wants to continue on hormone therapy, has a uterus and needs to take it.
So yes, we do need the progesterone, as we've just heard. So there are various types of progesterones. The natural one, body identical progesterone, is thought to be the better one because it mimics exactly our own progesterone and it has less side effects. And there are more old-fashioned types of progesterones called progestogens, which are in the pill, the combined pill, the contraceptive pill. So some women are very sensitive to progesterone, and we usually have a clue because they may have always had really bad PMT, you know, from a youngster in their 20s and 30s, or PMDD, it's called, when it's very, very severe. So they're fine until the progesterone phase of our cycle comes up in the last 2 weeks, and their mood drops, they're more anxious, more irritable, breast tenderness, and then they have their period, and they feel better again. They're sleeping, their mood improves. And that's the progesterone effect. So that's a warning sign to me. Or if someone has had postnatal depression, that's also a warning sign that they may be very sensitive to progesterone. Not always, and it can just happen out of the blue. So there's some workarounds. If with we always use the micronized body identical progesterone because it's the safest and the best in many ways. But if you're having a problem with that, you could take it orally, or you can take it vaginally, is another workaround. So some people are fine just doing that, because if you insert the capsule vaginally, much less gets into the systemic circulation all around the body, and that might be fine for some. Still, people may have a problem with that. So we then sometimes think about the Mirena coil, because only tiny amounts of the Mirena coil get into the circulation, and that can be very helpful for women. The other thing is people think they may be progesterone intolerant, and it's because their estrogen levels are too low. So once their estrogen levels get to a good level, I have found so many women say, gosh, I'm tolerating this progesterone actually now. I'm okay on that. If their symptoms weren't horrendous, they can often tolerate it again when we built up the estrogen levels. So there's the Mirena coil. There's actually looking at the old-fashioned progestogens, which in theory are supposed to be more side effects, but you know, we're all different people. And some people are better with the more old-fashioned progestogens.
Which is what I ended up doing, actually. I ended up going on Agestin, a microdose of that, and it was, I couldn't the micronized progesterone, and the anecdotal stuff I hear in my community is that it sort of sends them down a path of impending doom, and that was me. It was like the mental health aspect, but I never was, it's never explained to me from my gynecologist. It may just be it as a to what's happening in my estrogen. So again, to your specialist is what you're saying. Don't compare with your friend, your best friend, right?
So there are lots of workarounds, and
right,
and some people may take it less frequently, but have ultrasound scans to make sure that the womb is still protected. But that's a very specialist one-to-one conversation, really.
It's not generalized. So moving on, and actually, has actually asked a quick question that I'd love you to answer. Are there any contraindications for those other female health issues like endometriosis or uterine fibroids? Can they still take hormone replacement therapy if they exist?
Yes, the short answer is yes, they can. Definitely.
Okay.
Let's start with fibroids. Do you want me to explain about fibroids?
Yeah, okay, yeah, because there was actually a couple of questions about uterine fibroids.
So fibroids are very common. And they usually can give rise to bulky uterus and very, very heavy periods. They may even press on the bladder or the back passage sometimes if they're very big. Now, what happens is if you were not ever to have estrogen and you went through the menopause, your uterus would shrink and shrink and shrink, and the fibroids wouldn't be a problem then because they've gone. Fibroids are just muscle growing in a circular way, really, in the uterus walls, and they're very vascular, so they bleed a lot. So they fade away. But if you have HRT, you've got estrogen, which will keep it as it is, I'm afraid. So it will cure the menopausal symptoms and your future health risks, but it won't allow the fibroid to go away. But that might be fine because it's just giving estrogen back. It doesn't necessarily make it worse. Okay. And it can be taken. And endometriosis, yes, some people have some problems with the because estrogen can sometimes trigger the endometriosis a bit. But if they've had treatment with an endometriosis surgeon as well, we often are very successful giving HRT as well. But it just needs specialists and careful and monitoring. But yes, it's not a contraindication. Women can have it. They need it for their future health. They need it for their menopause symptoms, and we can usually help
work with it. Work with it. Yeah,
that's what I should say. Yeah,
I had to have a little chuckle because you said the back passage, and that always used to make me chuckle in school.
Oh God, did I say that? I didn't realise I said that.
It's the medical term for your anus, right?
Yeah.
Okay, so the last thing I want to talk to you about, and I sort of have a little bit of a soapbox about this, is because in the alternative medicine world, especially when women talk about menopause, they don't talk about menopause as being estrogen deficiency, which is the medical term for menopause. In fact, they actually call it estrogen dominance, and I hear this all the time, and women in my community will say, oh, my naturopath said I'm estrogen dominant, and now how do I detox my estrogen? And I just want to cry because it's I mean, I only know this from it's damaging. I only know this from speaking to experts like you, but essentially, can you talk about why the term estrogen dominance in menopause is like a misnomer and it's confusing? But then can you also sort of explain why the alternate health world are talking about this? Because I know they're saying because progesterone falls first and in a linear fashion, it means we've got more estrogen in our body, and that's essentially why they're using the term. So floor's yours, Dr. Rebecca.
So because I'm an orthodox medic, we don't recognize estrogen dominance because the way we know what happens is the ovary fails, and the main hormone of to do with ovulation, we run out of eggs, and therefore as we run out of eggs we fail to produce the hormones estrogen, progesterone and testosterone. But it is the failure of estrogen that really gives rise to these long-term health risks, and it's estrogen that's got to get back for our heart and bones, and it's the low estrogen levels that cause that, and it's the low estrogen levels that cause the flushes and the sweats, and the symptoms are all due to what we could call hormone deficiency, estrogen deficiency. And that's what results. At the beginning of the perimenopause, the progesterone may dip a little bit. So your estrogen levels are not high, but it's just relative to your progesterone levels that the progesterone levels do dip. And that's why I think they think that it's estrogen dominant, but it confuses women then, because they think, oh, I'm toxic, I've got too much estrogen. They haven't got too much estrogen, they've just got a low amount of progesterone. But often just replacing a little bit of estrogen and the progesterone for the wombs just corrects that balance very nicely, and that's what you need. But we always give estrogen. Yeah.
Good, and that's the perfect answer to the question, and also the fact that, like, I've spoke to Ansi Mukherjee, one of the top endocrinologists in the UK, and she's like, if you have estrogen or estrogen dominance or hormone imbalance, you're sick, you're seriously unwell, and you need to be under a hormone specialist, right? It's nothing to do with the menopause, and it's just confusing.
I've got toxicity because you feel so rubbish. You would think it's something toxic. It's not that. It's estrogen's good for us. Estrogen's really good. It's the low progesterone and the balance.
Yeah, and also the hormones are dynamic. They're on the move all the time. It's not like they literally fall.
Totally.
Okay.
Yeah.
I think we may have covered most things. I have been trying to incorporate some of the questions that people have been asking along the way as best as I can. One of the questions is like from one of the women, and I think we should just completely end it here before we talk about the app, is like, how do I know what stage I am in menopause? Like if you've had surgery, for example, chances are you're going straight into full menopause, but does it really matter? That's what I keep thinking.
No, it doesn't really matter. People kind of get a little bit obsessed about, am I stage 1, perimenopause, 2, 3 or 4 or postmenopause? It doesn't matter. You're estrogen deficient. I think we need to rebrand it as a hormone deficiency, like a thyroid deficiency. Many women would have no problem then to replace their thyroid. Yeah. If you came into me low thyroid, I give you thyroxine. Well, women are coming into me with symptoms low estrogen. Solution is give back estrogen. Okay, and that's how I think we should think of it. And so the stages really are, it's about symptoms. You know, if you're still having periods, you're perimenopause. If your periods have stopped, you're postmenopause. I think that's all you need to know. You don't need to know how far in or out, because you're never going to get out, because you're never going to get your hormones back.
You're never getting out. I love that. I mean, and that's the thing, we need to know that we're in this for the rest of our lives. And that's why I beat the drum about taking charge of your health, of course, right? So one of the things I wanted you to sort of finish on was that you have with Newson Health developed an app, and I've used it and I'm so impressed with it, and I think it can be a really valid tool. Can you just explain to women how to get it and what it does? Yeah,
with pleasure. The brainchild, of course, of Dr. Louise Newson, who set this up. I'm a director of the app as well. It's a free app, so that's what we really wanted it to be, to empower women. That's
my favorite price, you know. Free.
Yeah, exactly. Favorite price. So it empowers women. It's evidence-based advice on there, or evidence-based literature on there. It is a place where women can go and download and monitor their symptoms and can track their symptoms with their periods, so that they can see that often their symptoms may dip and worsen just before the period. That's the early signs of perimenopause, because just before our period, naturally our estrogen levels dip, and as the estrogen levels are low, it gives rise to symptoms. So some women, when they're starting out, may just have symptoms that week before the period, and this balance app will then highlight it. And the first question we're asked, when do we go to the doctor, is when you know that this is happening, there's some changes afoot, things are going on. So that is really useful to chart your symptoms, to document your symptoms. There's a community there for people to talk to each other, and women are brilliant at supporting each other and talking people through, and that's really supportive. There's enormous information on HRT, on alternative medicines, on exercise, on weight-bearing exercise, on diet, and lots of encouraging things to do to encourage women to participate. Perhaps if they wanted to do some weight loss programs, they can sign up to they're called experiments you can do to help, you know, reduce your sugar a little bit in your diet, or increase the exercise, and really good, and evidence about alternatives as well for HRT. So it's all about the menopause and what it entails, and you can download. The good thing about it, you put all your information in, and if the more data you put in, the more you'll get out. It will download a health report for you, and that's printed off, and you can take to your GP and say, look, this is saying all these symptoms which fit in with perimenopause, and I'd like HRT, and here's the information about HRT, because it's so safe. You know, the risk of breast cancer was completely overinflated by a misreported study in 2000, but it's still in our psyche. We know now that combined HRT for women over the age of 50, the estrogen-only HRT doesn't increase the risk of breast cancer, but combined HRT may increase the risk of breast cancer a tiny amount, but less than drinking two units of alcohol. a night. So it's incredibly safe, balanced by the benefits of women sleeping, getting back to their jobs, caring for their families, relationships not breaking up, protecting their future health, reducing their cardiovascular disease, reducing their risk of osteoporosis, dementia, type 2 diabetes. The benefits are up here. And one thing is really important to get across, of course, if young women have a menopause, which can come just naturally or as a result of cancer treatment or an operation for endometriosis to remove the ovaries, they must, it's a must then really, really, really must in most cases have HRT, because there's no increased risk of any breast cancer or anything like that when they're young to the age of 51, and they have an even greater risk on their health if they don't have
health
hormones.
side. Yeah, one of my favorite things about the app, and I hope it takes off in North America, is that obviously the tracking. I encourage everyone to track, but the fact that then you can get this report, and the whole point of the app for you guys was so that the women feel enabled, because when you go to the doctor, it's so difficult to describe what's going on, because also, you're in the middle of menopause, so you can't even talk.
Can't even get the words because you've got brain fog. And you don't know, do I do my muscle pains? Do I do my sleeplessness? Do I do my depression? What do I do?
Exactly. What's the one thing I'm going to highlight in my 10-15 minute window? So this is a really great, the app is called the Balance app, just BALANCE, Balance app. Yeah. And I highly recommend, I tell everyone to use it.
Oh, that's great, because actually it has global appeal. We've got 125 countries signed up, and it hasn't really been advertised fully, and we've got 125,000 downloads. That's
brilliant. Yeah, and even if it takes other countries a while to get on top of like the menopause management side from a medical perspective, at least you can go and advocate for yourself with actual facts that make this conversation easier. Yes. So listen, we have literally run out of time. It was so informative, and I did rush through a few things because I know there was more questions. Maybe we'll have you back. Dr. Rebecca, sorry, please say thank you to the rest of the doctors in your practice as well, because I know they've been so great and vocal about advocating for women. Thank you so much for joining us today. It's been so great. So how can people find you? Where are you?
So we're in Stratford-upon-Avon, Newson Health, Menopause and Wellbeing Centre, but the Balance app really, and the charity Louise Newson has started. That's kind of where we are really.
And you're also on Instagram.
Oh yes, sorry, yes, yes, I am on Instagram. There we are.
Lewis. Yes, that's great. So I'll put that in the notes, Dr.Rebecca.Lewis. Thank you again so very much for joining us. It's been such a wonderful conversation. And even though I've heard this so many times and I researched this in my book, I'm still like, oh my God, why is this still such a fight for women? And it's always so informative. So I really appreciate you. Thank you.
Absolute pleasure. Thank you for asking me. Very happy to do it again if you ever want. So thank you.
If we want a part 2, ladies, then let me know. You know how to find me. I always answer my emails. And so, yeah, I'm getting some thumbs up there. So that's great. Maybe that will happen in a month or 2. But again, thank you so much. Thanks, everyone, for joining us today. It was great to see you all.
Pleasure.
Bye. Bye for now.
Bye.
Thank you.
Bye.